Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon. Thank you, Jalal, for the kind introduction. This is a lunch-sponsored symposium, and I must admit I was sponsored by AbbVie, the company that produced the Gnrh Analogue. So I'll be here to discuss about the role of the Gnrh Analogue in the management of endometriosis. Sir William Osler is a physician from Canada, and he's one of the frontier of development of a lot of development within medical fields. And he once says that he who knows endometriosis knows gynecology. That means to say that endometriosis is actually a complex disease that still is a disease of enema. Until now, although research has been done a lot, still there are a lot that we still do not know about endometriosis. Okay. It poses diagnostic dilemma. It's a debilitating disease, a progressive disease, and occasionally we can say it's a disease with no cure because it depends on reproductive hormone, and endometriosis will only be stabilized once the woman reaches their menopausal age. Okay, you know this lady? She's the beauty and blonde of Hollywood, yeah? Marilyn Monroe, famous Hollywood star. Although she's rich and famous, but her life is very much afflicted by endometriosis, to the stage that she required right from her teen age to use monthly injection, until to the stage that probably she developed that dependence on the drug to cure her severe pain associated with endometriosis. And besides the part, she also suffered from the fertility associated with endometriosis. In one of the stories, it is said that Marilyn Monroe once went in for surgery because of the some gynecological problem, and she put a tape on her stomach, on her abdomen, saying that, "Dear doctor, please don't remove my ovary." So saying that she is so, her intention to keep the ovaries is so much because the intention to childbear is always there. But the disease is affecting her so much that it causes a lot of pain and also suffering to her. Okay. So endometriosis is a common disease that we see in gynecology. About 177 million women worldwide are affected by endometriosis. It is said that about 6 to 10% of women within the reproductive age group suffers from endometriosis. And among the infertility patients that we see, about 1/3 of patients who come to our clinic with problem of infertility actually suffers from endometriosis. And among the group with endometriosis, about 1/3 to half of them actually have problem with fertility. So what causes endometriosis is still not really fully understood yet, but it is noted that probably the ectopic endometrium are sensitive to the estrogen which was secreted by reproductive women, and this causes disorder of the growth of the ectopic endometrium, which is located elsewhere outside its usual place, that is the endometrium, and this causes an inflammatory response and also cause a lot of other problems. So the theory, there are three types. The implantation theory probably is the one that is the causative factors for endometriosis. But we have various types of endometriosis. For example, you have the adenomyosis, which is the ectopic endometrium are located within the myometrium. We have also superficial endometriosis, where the endometriosis are located within the peritoneal cavity. We have ovarian endometriosis, where the endometrial tissue is located within the ovary and causes monthly bleeding to the ovary, causing collection of blood, which we call as endometrioma. And we also have deep infiltrating endometriosis, causing a lot of adhesions, especially at the rectosigmoid area. So this is some of the illustrations, some of the pictures of endometriosis and how endometriosis can affect the reproductive tract, genital tract, and also reproductive performance of a lady. So you can see the adhesion between the bladder and also the uterus. You can see the adhesion between the uterus to the bowel, and this is a chocolate cyst where a black tarry blood is accumulated within the ovary. These pictures illustrate the adenomyosis, where the ectopic endometrium is located within the myometrium, and this causes a regular bleed inside the myometrium and subsequently causing an enlargement of the uterus, as we can appreciate from this histological section, cut section of the uterus. So how does endometriosis affect fertility? Definitely it affects fertility, because 1/3 of patients who come to our fertility clinic actually have endometriosis. So it can cause dyspareunia, resulting in patient not wanting to have sexual intercourse because of the pain that they experience. It can cause distortion of the pelvic anatomy because of the inflammatory reaction. It causes adhesion between the uterus to bowel. It causes adhesion within the fallopian tube, and therefore it causes a distortion in the pelvic anatomy. It also will secrete a lot of inflammatory mediators, which will definitely affect the process of ovulation, the oocyte quality, the sperm phagocytosis. It causes endocrine and ovulatory abnormalities because somehow or other it has an interference with the hormones. For example, the LH surge is defective in patients with endometriosis. And in our lab, where we examine retrieve oocytes from patients who has endometriosis, what we can appreciate is that the oocytes of patients who suffers from endometriosis are actually different from the oocytes from the general population. If we examine, my embryologist will say that, "Doctor, colour dia gelap. It looks a bit dark, granular, and usually they also will be associated with thick zona pellucida." You also have, when we inject or we fertilize the oocytes with the sperm, it causes an impact fertilization. That means not many embryos will be generated from the procedures. And when we implant the embryo, the pregnancy rate also is much lower because it will also interfere with the implantation of the embryos. And patients with endometriosis, usually the one that come to see us at our infertility setup, before they seek for fertility treatment, they actually have undergone multiple surgery. Surgery, 1, 2, 3 times surgery. And at the end, by the time they come and see us, their ovarian reserve are actually much reduced. So they don't have much ovary left. Even we stimulate with high dose, sometimes we can only retrieve a very low number of oocytes. So it's very difficult when we have low number of oocytes, the chance of pregnancy is always correlated with the number of oocytes that we collected. Okay, that summarizes how endometriosis affect fertility. Okay, distortion of pelvic anatomy, you can appreciate here. The fallopian tubes are adhered to the ovary and also peritoneal side wall, and that causes the distortion of the fallopian tube. But fallopian tube is an important structure where the sperms meet the egg. This is tempat mereka bertemu jodoh, sperm dengan ovum tu dalam tube fallopian. So fallopian tube tutup, restoran tutup, tak boleh jumpa kat situ. So distortion So this if you can appreciate, this dark granular oocytes are associated with endometriosis. And also we have, when we develop the embryos are poorer in development. Okay, as I said before, reduced ovarian reserve from multiple surgery. Not only multiple surgery, but fibrosis itself, because of inflammation, the fibrosis itself can cause reduced reserve of the ovarian oocyte pool. Okay, so how do we manage patient who has endometriosis, either on the basis of pain or infertility? I think this is a summary, a good chart, a good summary of how we manage patient with endometriosis. Say for example, a patient presenting with pain or infertility. For example, a patient presenting with pain, cyclical dysmenorrhea, and on examination there is evidence to suggest that probably this patient has endometriosis. If the pain is very mild or moderate, we can consider giving empiric treatment with OCPs or progestin. OCPs, like what Professor Gnrh says, suppress the ovulatory process. So therefore there will not be severe with no ovulation, and therefore pain can be suppressed. If the patient has severe pain or moderate pain that disturb her daily activity, and there is also evidence to suggest endometriosis, we occasionally have to confirm the diagnosis by laparoscopy and do a surgical excision and ablation of lesion. And immediately post-surgery, we have to suppress the endometriosis. That means we have to give medical treatment to prevent the progression of the disease. And if the after surgical excision, subsequently if patient is not on treatment, we still have to follow up the patients to see the disease recurrence. If there is evidence of recurrence, we either have to again repeat the medical therapy, or in patient who has completed the family, and if the pain is severe enough and the recurrence is there, sometimes we may consider doing a surgical intervention. On the other hand, if a patient presents with infertility and we have worked out the patient, we did a seminal fluid analysis and other infertility workup, sometimes depending on the stage, depending on the stage of the disease, we actually will offer either an ovulation induction or in vitro fertilization. So that I will actually elaborate further. So the medical management of endometriosis consists of various modalities of treatment, and NSAIDs to reduce the pain, OCP, progestogen, Gnrh agonist, levonorgestrel intrauterine system, implanon, danazol, and specific progesterone receptor modulator. As you can see, majority of this treatment will actually causes suppression of the ovulation, and therefore this is actually a dilemma for us. When patient with endometriosis coming to see us with fertility and also pain, so sometimes you have to choose which one do you want to treat. If patient, the main problem is actually pain, so we have to treat based on this medical treatment, but at the same time we have to counsel patient that medical treatment does not increase the chance of fertility. All these medical treatments actually suppress their own chance of conceiving naturally because it suppresses the fertility. So basically this is what we counsel the patient. It is whatever modalities of medical treatment that is available, it be able to control the pain and progression of disease, but it's usually limited by their side effects. For example, if you give Gnrh agonist, it is good, but again, it is associated with side effects, and one of the deleterious one is actually the bone loss. So we may consider to Gnrh Analogue, we add back therapy to maintain the bone mass. Yeah? And also this medical treatment has a negative impacts on fertility, and there is no evidence that medical therapy actually improves fertility. So what is the treatment for patients with endometriosis who are infertile, who wants to get pregnant? So in formulating management, what are the management that we are going to offer to patients who has infertility, at the same time suffers from endometriosis? A few considerations has to be taken. For example, you have to see what is the age of the female patient, what is the duration of infertility, what is the stage of endometriosis, is there other associated fertility factor, for example, what is the sperm parameters of the partner, and we have to also to see what are the available resource in our setup that we can offer the patient at that junction. So endometriosis is staged surgically, and we staged by the American Fertility, AFS staging, American Fertility Society staging of endometriosis. Basically, we stage them into, it's not working, into mild endometriosis, where we can only see a little bit of endometriosis probably located in the peritoneum, moderate endometriosis, and severe endometriosis. So depending on the stage of the endometriosis, we have to formulate our subsequent management. In stage 1 and 2, that is minimal and mild endometriosis, it is noted that if we can ablate, we can burn the endometrial implants, it is associated with a small but significant increase in live birth rate. For example, you investigate the patient, you did a laparoscopy and you noted there is an ectopic endometrium which is suggestive of endometriosis. So are you going to ablate or not going to ablate? So if you're going to ablate, you have the chance to ablate, you better ablate because it is associated with a significant increase in live birth rate. But do you do laparoscope for all infertile patients? When you investigate, you do laparoscope. If you do not find anything to suggest that this patient have endometriosis, the most usually what we do is to check tube by HSG. We don't actually offer laparoscope. Only in patients when we suspect there is evidence of endometriosis, for example dysmenorrhea, or in your scan you see a retroverted uterus with fixed ovary to the uterus, then only you do a laparoscope. Otherwise, checking tubal is enough by hysterosalpingogram. Okay. So the benefit of laparoscopy treatment, that means you increase the pregnancy by doing ablation, okay, is insufficient, however, to recommend routine laparoscopy solely to increase the likelihood of pregnancy. That means you don't do laparoscope routinely. You only do in suspected cases, and if you do and you suddenly see an endometrial implant, then only you ablate. Okay. So when laparoscopy is performed for other indications, the surgeon may consider safely ablating or excising visible lesions of endometriosis, and that can actually increase the chance of pregnancy. Now, when you diagnose the patient having mild or minimal endometriosis, what do you do after that? You say, okay, pergi balik, baca doa, ya, pergi balik bersama, pergi balik makan makanan sihat, atau apa you kena buat? Okay, usually we do not want to leave the patient with expectant management. We must have a plan of management for the patient. And what is our plan? That means we have to actively manage this patient. Yeah. What do? We usually advise the patient to go for ovulation induction with intrauterine insemination. Okay. Why? Because it is noted from this study, okay, that if you wait, you don't do anything after you diagnose the patient to have minimal mild, you just wait, patient will probably get pregnant. But if you do interventions, and you don't wait so long, the chance of patients getting pregnant is actually higher. So in our setup, once you make a diagnosis of endometriosis, minimal mild, I usually will have a plan for the patient. That means we will cepat-cepat, we will plan the patient to go for ovulation induction and IUI. Ovulation induction means we induce the patient with gonadotrophin so that the patient produce a better quality egg and a higher pregnancy as compared to giving just clomiphene citrate alone. But again, you have to take consideration into cost. Yeah. Okay. So live birth rate is 5.6 times higher in couples with minimal to mild endometriosis after ovulation induction with gonadotrophin and IUI as compared to couples after expectant management. Alright. So this is basically what we do. Okay. So we see the patient around day 2 to 3 of menses. We do a baseline scan, and we subsequently subject the patient with injection of gonadotropins, FSH, and we monitor the growth of the follicles. And once we see a good follicle size, about 16 to 18, we trigger with HCG. Yeah? HCG will induce an LH surge and causing ovulation, and 36 hours after the HCG, we will ask the partner to produce sperm, which we will then process and put inside the uterus. So this is ovulation induction and IUI. So basically, partner produce sperm, so sperm will be processed in this we centrifuge the sperm, basically to separate a good sperm from an immotile sperm, and we put a highly good sperm at the fundus of uterus. So how does IUI increase the chance of pregnancy? First, you are putting a processed sperm, which you give a bit of makanan, everything inside there, so the sperm will stay longer, will live longer, about the 72 hours. Secondly, we inseminate the sperm at the fundus of uterus. So sperm hanya berenang Laut Cina Selatan instead of Lautan Pasifik, so shorter distance. And thirdly, you put the sperm at the time when you know ovulation will about to occur. So you know that that is the right time where they will probably meet. But having said so, the chance of IUI, pregnancy with IUI and gonadotrophin is only in the range of 15 to 20%. So we usually will do IUI for about 3 times to 4 times. Yeah. Okay. In a woman with stage 3 to 4, that means they are advanced stage, they are moderate and severe stage, what do we do? Yeah? So we diagnose them, okay, we do surgical therapy and surgical management. That means usually stage 3 and 4, you will have an endometrioma, you will have an adhesion between uterus to the bowel. So you resect the endometrioma, you release the adhesions, so you remove as much as possible the endometriotic spots, yeah? And what do you do after that? Yeah? So the benefits of surgery in severe disease, when you do surgery in severe disease, you restore the pelvic anatomy, you remove the implants and endometrioma, and therefore you decrease the inflammation. So, however, you must make sure that this surgery is done by people who are expert in doing this. I must say that I'm not very good at doing this, so that's why I always ask my colleagues who are better in their surgical skill to do this procedure, so that I can actually have a better outcome for my patient when I stimulate the patient. So you must pay attention that you don't remove so much of the ovarian tissue. At the end of the day, when I want to stimulate the patient, I don't have much being left. So you remove as a disease one, but you don't remove so much. Okay, and surgery is best postponed until fertility desired. So that means if you see a patient at the age of 25, not yet married, you see a cyst there, suspected of endometriosis, possibly you can actually start the patient with medical treatment first. Because if you do one surgery, you already remove part of the ovarian tissue. You already reduce the reserve, and subsequently she doesn't find her Mr. Perfect yet. Okay, so she wait another 3 to 5 years, so the endometriosis will keep on growing. So that's why surgery is best postponed until fertility is desired, because repetitive surgery may actually reduce the ovarian reserve. Yeah. So it is imperative that the surgery that is going to be done is well planned, with future reproductive treatment options discussed and referred to the appropriate expertise. So to do or not to do surgery, usually when patient is about to embark on fertility treatment, when the cyst size is more than 3 cm, we would actually recommend the patient to do surgery. But of course, surgery has its pros and also cons, because if you do surgery, the benefit of it reduces the risk of cyst complications. Yeah, it facilitates transvaginal access to ovarian follicles. When you do ovarian scanning, you can actually see the follicles. If you have a cyst there, the cyst will obscure your view. And also, when you want to do pickup, egg collection, the cyst will actually sometimes be contaminated when we do the oocyte pickup. But again, the risk of doing surgery is that you will actually reduce the ovarian reserve. Okay. So surgery must be complete and performed by qualified gynae surgeon with experience in dealing with endometriosis. Okay, and it has been noted in this study, if you do repetitive surgery, okay, either surgery or better, or the IVF and embryo transfer is better. That means after surgery, you wait and subsequently patient had another operation, or after surgery you directly put the patient into IVF. It is noted that the odds ratio of doing IVF ET is higher in terms of pregnancy in patients who have endometriosis. So once you diagnose the patient as stage 3 to 4, so medical therapy should be discouraged, okay, and in patients who have endometriosis and subfertilities, except in patients undergoing IVF. What we do is that when patient diagnosed as stage 3-4, we say to the patient, usually what we do in our setup here, my colleague will do, probably somebody will do the operation and say, oh, this patient has stage 3 to 4. So what do we do next? We're going to counsel the patient for IVF treatment, since this is also an IVF center. and while waiting, we are going to give a Gnrh Analogue for the patients. So in patients undergoing IVF, prolonged Gnrh agonist treatment prior to IVF, before you do IVF, you give Gnrh, actually may improve the fertility rates in advanced endometriosis. Okay. So ART is not complementary, but is actually needed. Okay. So especially if the tubal function is compromised, there is also male factor infertility, and patient is already in advanced stage 3 and 4 endometriosis. Okay. So does it differ when we do IVF in patient who has endometriosis? Does it differ from other patients? Yes, it do differ. Yeah? People make cakes with different recipe. It is still the same. Yeah, when you do IVF in patient who have endometriosis, you have to use a different kind of cheese and butter and so on. So in IVF in endometriosis, usually we will choose an ultra-long protocol. What does that mean? That means we suppress the patient with Gnrh agonist for 3 to 6 months, okay? And subsequently only we wake up the ovary. By doing the suppression, what happened is that we actually will suppress the disease. The endometriosis, the quiescent one, will actually be suppressed. And also, you know that I mentioned just now that in endometriosis you have a lot of inflammatory mediators in the peritoneum. So you will also suppress the peritoneal mediators, and that could actually explain why the pregnancy rate in patients who use the ultra-long protocol is actually higher compared to the usual recipe of doing IVF. Yeah? So ultra-long protocol and EC is the protocol of choice. You don't do conventional IVF. IVF, you just put 1 sperm to 500,000 of sperm, 1 egg to 500,000 of sperm, biar the sperm berenang sendiri tembus telur tu tak. Tapi in endometriosis, you do EC because there is always, you usually have problem of fertilization. That means you assist the sperm to enter the oocyte zona pellucida. So ultra-long pregnancy, ultra-long protocol has been shown to increase the odds of clinical pregnancy by more than 4-fold. Okay. So Gnrh agonist, what Gnrh agonist does is that it is similar to the gonadotropin, only that it has a receptor affinity which is 20 times higher, so it will be bound to the receptor, and initially it will cause a flare-up effect before about 2 weeks after that, when it will have a suppression effect. So when you give the patient about 3 to 6 months, so you have a suppression effect, so all the endometrium activity will be quiet, and all the inflammatory mediators in endometriosis will actually also be quiet. So Gnrh and endometriosis, quiescence of endometriosis disease and is suppressed estrogen, the endometrial implants will degenerate, will be deactivation of peritoneal macrophages and inflammatory mediators. And also the beauty of giving agonists is that you have a synchronous follicle development during stimulation, and therefore it is postulated that you can probably have higher number of oocytes. So in this meta-analysis of 3 trials, it is noted that the odds of pregnancy is actually higher, more than 4-fold, if you do ultra-long protocol in patient with endometriosis. So our approach, what we do in our setup is that, one, we diagnose the patient as having moderate or severe endometriosis. We counsel the patient for ART, and we give 3 to 6 months of Gnrh agonist, for example, Endocrine, and subsequently subject the patient to ART. So we don't wait for the patient to have their menses. So right after that, when the patient is amenorrhea, we subsequently stimulate the patient. So this is a data collection which was done by Dr. Rizwan among our endometriosis patient, which we divide into stage 2, 3 and 4, and subject the patient for IVF-EC. So we noted that if you can appreciate here, the antral follicle count is basically the baby eggs that we count. We calculate how many eggs remain there. In stage 2, because of the nature of the stage, which is very early still, the AFC is higher as compared to in stage 3 and 4, where the antral follicle count is getting lesser, probably because of the chronicity of the disease and probably also because of the multiple surgeries that the patient has underwent before they actually embark on fertility treatment. And what we noted here also is the number of oocyte retrieved in patient who has stage 2 is actually higher compared to stage 3 and 4, and also a higher clinical pregnancy rate in stage 2 out of 18 out of 26 patients, which is 69.2%, in stage 3 and 4 about 38%. So this gives a reasonable pregnancy rate if you compare to an overall pregnancy rate in our patients. So a comparable pregnancy rate with Gnrh agonists. So as a conclusion, medical treatment of endometriosis is actually reserved for symptomatic women with pain. Medical treatment does not improve pregnancy rate, and in fact it delays the spontaneous chance of getting pregnant. Surgical is beneficial in minimal and mild endometriosis. Surgery is controversial in endometriomas owing to potential effect of ovarian reserve, but you really have to see if the size is usually 3 to 4 centimeter and the patient is about to embark on fertility. Usually we would suggest to remove the endometrioma before proceeding with fertility treatment. In minimal and mild disease, ovulation induction and IUI is actually the first line therapy. In moderate and severe disease, IVF and NREC with ultra long protocol, which is 3 to 6 months of Gnrh agonist, is the treatment of choice. And surgery should be in expert hand, and if possible to postpone the surgery until fertility is desired. So until then, we start the patient with medical treatment until the patient reach an age where fertility is actually desired. So with that, I thank you for your kind attention.